One of the, for me, best measurements by means of diastolic dysfunction is left atrial strain. It's a bit of a new kid on the block, and we already discussed the pulmonary venous signal. It can help to determine left atrial filling pressures or left ventricular and diastolic pressures if there is no mitral stenosis present, and it also can help grading diastolic dysfunction. So in the guidelines from 2016, you can see that the indeterminate tree over here shows you that E to A ratio is below or 0.8 with an E wave above 50 centimeters per second, or an E to A ratio above 0.8 to below 2. And there are three criteria to be evaluated. First of all, of course, again, the average E to E prime ratio. If it's above 14, it's pathological. The TR velocity, if it's above 2.8 meters per second, it's pathological. The LA volumetric index above 34 milliliters per square meter, then it's pathological. When you only have two of those criteria available, and one is positive and one is negative. For example, the LA volumetric index is 33 milliliters per square meter and the average E to E prime is 15. The TR velocity is not measurable. Very often you can encounter such a situation, or switched around, the average E to E prime ratio is 13 and the LA volumetric index is 36 milliliters per square meter. So you have one positive, one negative, and then it's basically not possible to determine if left atrial filling pressures are elevated, and grading of diastolic dysfunction is also not possible. But for those situations, we have, first of all, the pulmonary vein signal, but also left atrial strain. So we want to know, how does left atrial strain look like? We need to perform this measurement in a 4 and a 2 chamber view, basically. And then you see this typical curve over here. So that's what a left atrial strain looks like. The LA volume can be measured in several phases. The LA function per se is complex and time intense. LA strain makes it basically easier, faster, and in my personal opinion, better to look at the atria, not only the left but also the right atrium. The left atrial strain basically measures all of the phases of atrial function. We discussed it already in previous videos, but to repeat, you have here the left atrium, this is the right atrium, the left ventricle, the right ventricle, interventricular septum, interatrial septum. And when you perform these measurements, you have this automated measurement where you see that there are some markers set at the mitral valve annulus, and basically you want to have the entire left atrium being measured. So you will have pulmonary veins, here also pulmonary vein and the left atrial appendage, basically making it harder to measure. So you have some areas where you do not have proper speckles, but that overall is not very relevant in a real life clinical scenario. Then when you have an optimal tracing, you see that the left atrial wall is traced. If it's a bit thicker, maybe make the strain a bit thicker, but normally the strain, the area of interest, the region of interest will be relatively thin. As the left atrium, the right atrium, they have thin walls. And then we get this strain curve. We have an ECG, we have the R to R trigger, we have here a marker with a pre-A. The pre-A is basically just before the P wave. That can be harder to see. By means of the curve, it's easier. So we start from a 0 point, we go up. Here in the range of 35 to 40 is probably normal. 30 to 35, depending on the age, can also be, of course, normal values. Below 30, it might be pathological. Below 20, it's significantly pathological. Then we have here the second phase, the conduit phase. So first is the SR, the left atrial strain reservoir phase, 35%. Then we have this conduit phase. So the LSR is the filling, so the maximal filling. So that's why it is a positive value. Then the conduit phase ends with the pre-A when atrial contraction occurs. So the conduit phase is already emptying of the left atrium. It's here visible. So left atrial strain conduit phase minus 19%. And then we have after the pre-A, so the P wave, the atrial contraction. So also before the A wave, so to speak. So just before atrial contraction, it starts, and we have then to go back to the 0 point. And then we get also a left atrial strain contraction phase, and that's minus 16%. So overall, we have now the entire strain curve with all the functions of the left atrium. It's recommended to do the R to R gating as we have it. Here you can do a P to P gating, but it's difficult to see because here's the P wave. You see a lot of other waves in this ECG, so the P to P gating I wouldn't recommend personally. 0 is the beginning, therefore, of the reservoir phase. It's a bit different when you use a P to P gating, but the ECG, as said, can be a bit inaccurate, it can be difficult, so therefore it's rarely used and the values are a bit different. I'm not going into detail about that because it's nowadays also recommended to do the R to R gating. As said, the left atrial strain reservoir phase, it's positive, the left atrium distends. The conduit phase, the contraction phase, the left atrial strain conduit and left atrial strain contraction, they are negative. The left atrium is getting smaller, it shrinks. Here's an overview of how it looks like. The strain curve again, the reservoir phase, the conduit phase, the contraction phase as well, and how a normal curve should look like. And here I have the normal values as well. The left atrial strain reservoir phase in the range of 39%. There are some variations, great variations to a certain degree. The contraction strain in the range of minus 17%. Again, it has to be mentioned, the values can be relatively different depending on the patient population, depending on the training status of the patient, and of course the age. You also see when those time points occur: the aortic valve opening, aortic valve closure, mitral valve opening, and mitral valve closure. Conduit phase again is in the range of minus 23%. This is how it looks like with an ECG. So the left atrial contraction strain is just at the region just before the P wave. Now, using it in a 4 and 2 chamber view makes it, of course, more accurate. So we had one vendor, this is a second vendor, where you see the tracing of the left atrial strain. The reservoir phase in this case is 40%. The conduit, so this is left atrial strain, reservoir phase 40%, conduit phase minus 22.9, and contraction minus 17.1. So this is a perfect example of a normal left atrial strain, actually. The correlation of left atrial strain with left ventricular and left atrial filling pressures is better if it is used as a standalone parameter compared with the left atrial volumetric index. Nothing in diastolic dysfunction should be used as a standalone parameter overall, so that also has to be kept in mind. The higher the filling pressures, the lower the atrial strain, the left atrial strain will be. The left atrial strain, the reservoir phase below 11.1% shows a restrictive filling. Below 16%, you can be already very sure that elevated filling pressures are very likely. There is an inter- and intra-observer variability, but it is comparatively to other measurements like E2E prime or the LAVI significantly less. Here's a normal strain curve again for you to see. That is also quite nicely depicted in the British guidelines of diastolic dysfunction 2024. You can see the variations also, what is normal and what is definitely out of this normal range. Then we have a grade 1 diastolic dysfunction without significantly elevated filling pressures, or with normal filling pressures. And we continue to grade 2, so when we already have elevation in filling pressures, normally the left atrial strain will be significantly reduced. And when we talk about grade 3 diastolic dysfunction, the left atrial strain, the reservoir phase, doesn't reach 20 here at all, so it's significantly decreased. So keep that in mind, how the strain curves look like when you actually evaluate patients by means of left atrial strain. Here are all the curves for you to see that you get a better overview how it should look like and how it can look like when you have a pathological situation. For me personally, I do think the probably best cutoff for a significantly diseased left atrium is in the range of a left atrial strain of 20%. So below 10% is devastating. So the left atrium might be entirely fibrotic because of such a low strain value that shows that this atrium significantly took damage by means of, for example, filling pressures. If it's above 30, the left atrial strain, the reservoir phase, you can be very sure that it is normal. The contraction strain is also something which can be used for grading diastolic dysfunction and filling pressures. The lower it gets, the more likely elevated filling pressures are. Also keep in mind you need a good left atrial filling to also have a good atrial contraction. So if the left atrial strain, the reservoir phase will be reduced, also the contraction phase will be reduced. The conduit strain for me has less relevant clinical meaning. So in my report, I mostly talk about the left atrial strain, reservoir phase and contraction phase. Continuing with pitfalls. So this strain is an amazing tool. Left atrial, right ventricular, left ventricular strain, basically all are amazing to use. The problem is they have pitfalls as well. So this is a significant limitation. This is an automated measurement, and we do see here left atrial strain measurement. But note that the atria, they are cut off. So if you do not have an optimal image quality, so this is a very, very strong example, I would say. So you see almost half of the atrium is missing. In any case, keep in mind that you should see also the roof of the left atrium. A little bit below the left atrial roof, you should have the field of view. For shortening of the left atrium is most commonly a pitfall. You have an LV optimized view, and because you have the LV optimized view, the left atrium is a bit foreshortened. So keep in mind that you can perform a specific view for the left atrium as well. Always save a specific left atrial and right ventricular focused view to make sure if you want to take those measurements in a later stage that you have them at hand. It's nothing more frustrating when you forget, for example, a two-chamber view, left atrial focused view. I did forget that quite often, so I'm speaking from the heart and from personal experience. Take the time and just take 1 or 2 loops focusing on each and every heart chamber. So left atrium, right ventricle, and also the left ventricle, of course. In atrial fibrillation, the left atrial strain, the reservoir phase, very often will be very low and below 20% due to the chronic fibrosis, chronic injury of the left atrium. If you have higher values, that is also something which could speak in favor of cardioversion and a healthier left atrium and a not so long time where patients did suffer from atrial fibrillation. So those are the values by means of age and sex. You see that the older you get, the lower the values are, but there is a broader range. Nevertheless, normally in male patients, in young male patients, values above 50 you will rarely see. Values above 30 you will rarely see. So think about disease. The same for elderly patients. I mean, 65 is not elderly, but still in younger patients, I would go the same way and say below 30, think about pathology. Below or above 60, rarely I do see that. Above 65 years of age, you see a little bit of a reduction in strain, and then very often the good cutoff, I would say, when you also start thinking about an early stage of, for example, restrictive cardiomyopathy, might be 20% by means of the reservoir strain. Same holds true for females. The values are a bit different. Overall, the younger you are, the healthier the atrium is, the more longitudinal function you will see. The contraction strain is actually a negative value for purposes of visualization. Here it's without the negative value, so also the contraction strain can be different. Now, when we have very young, healthy individuals, especially sport individuals, it can be lower. The values can be significantly lower because atrial contraction is not that important. The older you get, the more important is atrial contraction. That also explains that the normal values are higher in comparatively older population. Now, one is for sure, diastolic dysfunction is not easy and not easy to understand that left atrial strain can help. This actually is taken from a publication from two of my acquaintances, Daniel and Evgeny, and they did show that the pathological left atrial strain is actually better than the left atrial volumetric index by means of grading diastolic dysfunction into elevated and not elevated filling pressures. Left atrial strain plus the left atrial volumetric index gives you a better possibility to detect actual diastolic dysfunction, also left atrial elevation of filling pressures. The left atrial reservoir strain below 23%, you have the double the amount of hospitalizations and one NYHA class higher in patients with diastolic dysfunction. So a powerful tool we have at hand. If you look now at the differentiation in between normal and elevated filling pressures, the cutoffs are below 20%, so the left atrial strain reservoir phase very often speaks when it is below 18% for a pulmonary capillary wedge pressure above 12 millimeters of mercury. It is better when we have an ejection fraction below 50% versus an ejection fraction above 50%. If the left atrial strain reservoir phase is below 16%, you can be very sure, independent of ejection fraction, that the pulmonary capillary wedge pressure will be significantly elevated, so above all 15 millimeters of mercury. The left atrial strain contraction phase below -14, so -15, -16, -17, identifies normal filling pressures quite nicely. So the pulmonary capillary wedge pressure will be below or 12 millimeters of mercury if the GLS is -18% or more negative. If you have a more positive contraction strain, so above 8%, -8%, it identifies elevated filling pressures. And the lower the values are, the better the detection is. I want to show you some examples here. We have a likelihood of normal filling pressures, apical hypertrophic cardiomyopathy. You see here the hypertrophy is in the apical segments, the so-called Spades sign, and you see the left atrial strain. You have a nice strain curve over here. The detection of the pre-A was also quite nicely, and we have a left atrial strain reservoir phase of 28% and the contraction strain of -13%. This patient also had already an episode of paroxysmal atrial fibrillation, but all the measurements we took here show that filling pressures are most likely in the normal range. Now we have a different patient. We have a patient with coronary artery disease after a large anterior myocardial infarction. We have huge wall motion abnormality in the apical regions. We have again a nice tracing of left atrial strain. What we can see here nicely is also this strain curve, and we have a left atrial strain reservoir phase of 43%, the contraction strain -18%, so also no elevation in filling pressures is likely. When we take now at elevated filling pressures, we have here a case of heart failure with reduced ejection fraction. Ejection fraction is severely reduced, definitely below 30%, I would say 20 to 25 probably. And we have this very large stiff left atrium, also a large stiff right atrium, dilated right ventricle. The left atrial strain reservoir phase is 6% and the contraction strain -2%. So this is for a patient also in sinus rhythm, basically catastrophic by means of the measurement. Also, the volume is significantly larger compared to the patients before. So this is a significantly reduced left atrial strain, reservoir and contraction. It is pointing towards significant elevation of filling pressures. Here now we have a different example. Again, it's sinus rhythm. You see this nice curve over here. This looks like a normal left atrial strain curve. The pre-A is nicely detected. And we have a reservoir phase of 12 and a contraction strain of -5%. This is a case of a patient with heart failure with preserved ejection fraction. Ejection fraction was in the range of 55%. And we do see those values which denote that elevation in filling pressures is very, very likely. So let's go the easy way. Strain has, of course, limitations that has to be known in atrial fibrillation. You can only use the reservoir strain, of course, not the contraction strain. But the reclassification of this indeterminate situation is up to even almost 100%. So that can be used in many cases to actually determine are filling pressures elevated or are they normal. It is again no standalone parameter. If I could choose a parameter to bring to a faraway island to have an idea about diastolic dysfunction in patients, I would use the 4-chamber view of the left atrial strain. The second one would be, of course, the 2-chamber view, and if I can choose a third one, it would be the pulmonary venous signal. Overall, it's way easier to perform and way more reproducible compared to other measurements like the pulmonary venous signal, because the vendors have actually quite robust algorithms which make it easier and more reproducible. But with all in medicine, with all in echocardiography, you should perform around 80 to 100 measurements yourself to get a feeling if the measurement is reliable or if something is still off. So left atrial strain can work quite well. Here is again the cutoffs for the elevation in filling pressures for you to see, which I think works very often very, very nicely. To summarize, let's keep it simple. Determine the indeterminate left atrial strain reservoir phase below 18. Filling pressures are likely. The contraction strain above, so more positive than -8%. Elevation of filling pressures are likely when we determine the indeterminate. Left atrial strain, again, this is a case of a patient. He is an athlete, but he also did and does steroids. So we have a significant dilatation of the ventricle and also the atria, the right ventricle as well. We also have significant thickening of the left ventricle. But even though he is in a situation where the heart doesn't look morphologically normal anymore, the measurements are still in a normal range. We have a reservoir strain of 42%. In sport individuals, the contraction strain, as I said, can be a little bit lower because the ventricle already sucks all the blood in, and for left atrial contraction there is not so much blood left to actually be responsible for the filling of the ventricle. Also keep that in mind for the high E to the small a ratio. The contraction strain is therefore lower. The conduit strain is also normal, so it is easy, it is reproducible. You can use it in atrial fibrillation, it has prognostic relevance, and in this case it also shows that the atrium, at least the left atrium in this case, is a bit dilated, but still the contraction, the reservoir phase, the conduit phase, they basically work normally. So this atrium is less likely to already experience significant damage by means of fibrosis, for example. So this is a very fun and easy to use and relevant measurement.